Okay, so 3 stab incisions were done in the back part. So you have to distinguish in regards to what are you going to lengthen, the calf itself, the recession of the gastroc, or an Achilles lengthening versus a block of bone in the front to increase the motion of the ankle joint. The ankle joint has to acquire at least 15 to 20 degrees. So when I pull this ankle, you want to compare this bone called the fibula, the outside of the bone, compare it to this column. We clearly see it's greater than 90. It's actually about maybe 22 degrees just by eyeballing it. As you can tell, we're going to compare it to the other foot and you can tell the difference. So that is achieved. The sagittal motion, it's up and down, is achieved in regards to gait and proper running and so on, and preventing pronation and depreciation of the arch. So that's been done, accomplished by a hook procedure in her situation, which is 3 stabs to lengthen the tendon. This little cut involved a break of the heel in the front of the heel rather than the body of the heel, and we had to put a bone graft and a little tiny plate and screws, and it aligned it phenomenal. What that does is prevents the foot from going towards you guys. That, I call it the windshield wiper. It's actually called transverse plane. So that is phenomenal, and it's beautiful. Second thing, if we look at it from straight up, the kneecap, centrally of the knee, it should hit the second toe. And that's exactly where we got. Knee to second toe. And that's where we have to be. Third is a little procedure on the side. I call it the modified Kidner's procedure. We took that extra bone she had, shaved some of the bone, and anchored the tendon upwards, called transposing the tendon. And that basically resolved the discomfort as well as aligning properly the medial column, the inside of the arch. So overall, that looks phenomenal. And then lastly, we did a little procedure on the big toe, which I can't see the cut personally. Not trying to be arrogant or so apparently there was a cut somewhere here. So yes, she healed phenomenal. And we do not see the cut, and the toe is beautiful and straight in comparison to before. This has to be now addressed in comparison. So when I pull, you can see that little extra bone that she has on this foot. It's protruding outwards, weakening the tendon further. This needs to be removed. This needs to be shaved. This needs to be pulled up like we did to the other side. And you saw what happened to the arch when I did that. Second, we need to lengthen the calf or the Achilles to create more motion at the ankle. And lastly, do the same on this side, which break the heel, put the bone graft, and lengthen the column. And so therefore it prevents the foot from going outwards. As you can see, the foot wants to go this way. And then the weight is being dumped to the forefoot, as we said before, to prevent the weight onto the big toe. We're going to fix that big toe as well, like we did to the other side. So those are the things that need to be done into this in regards to this foot. So if you can come to this side, I just want to show you the range of motion. The range of motion of the ankle. So I'm going to have the knee extended, as you guys can see, and we're going to compare the fibula, which is this bone, to this column, which is the metatarsal. So we're going to try to compare that and try to pull as much as we can. Obviously, clearly, it's not going past 90. And so there is a restriction or limitation of the ankle range of motion. And what we want to do is make sure that with the knee bent now, bend the knee if you may, the ankle provides further motion. So now we know that it is one muscle versus two, and to decide which procedure to be performed, a gastric recession versus a tendo-Achilles lengthening. And so that's, it's called a silver schooled maneuver, or to perform to see the ankle range of motion. So nonetheless, this thing with that thing, pulling up, limited, knee bent, more, and you heard it pop. So that needs to be addressed, and she likes to go outwards, as you can tell. So we got to see the other foot now. Do it again on this side with the knee extended, and you can see, look how much. And the foot doesn't want to drift outwards. So we achieved exactly what we need to do. And obviously it's going to increase more now when the knee bent. It's going to increase further. So straight, and it's nice. So we're comparing this side to that side. We're getting much, much more than 90 degrees in comparison to the other foot. So let's look from the bottom. The bottom second toe to heel is exactly where it should be. Let's do this side. Second toe is far away from the heel because the forefoot is drifting, called abduction, meaning it's moving outwards, and this is bulging inwards and this is rotating. So it's not in alignment, and the knee is not even close. Okay, we're looking at a foot deformity obviously in the front, and obviously in the back part. We're gonna look from the rear as well. The arches are definitely depreciated. They're not totally collapsed. I can still put my finger underneath. And so that's a different video that we'll talk about in regards to the foot types. This, as we can see, the front of the foot and to the back part, we can see the ankle bones are not aligned where they should be. The arch wants to depreciate. The weight is being thrown. We call the unlocking of this joint called the mid-tarsal, and the body weight transfer to the forefoot. This is unacceptable, creating strain along this area that continues, and a pull, traction along the tendons and the nerves, and a pull called the fasciitis on the bottom. And then the weight is being thrown to the forefoot, excessive motion along the outer bones. Genetics starts to play, called the bunions and the bunionettes, and the hammer toes and so on, for stability and stabilizations. So that's what we have from the front. Now, when I go to the back part, I'm so sorry. When I go to the back part, we can see the bowing and the rotation of the heel. And so when we go from the rear, we can see all the toes stick out. And this is a classic sign that bulging or escaping. We can see that right there. So that needs to be stopped and addressed. So as we can clearly see, this area and that area. So now that was not fixed, will be fixed. We want to show you the foot that was fixed, that was exactly the same as that. So please turn around if you may. Now we're looking at the foot that was fixed. Try to straighten out if you could. This is the kneecap, straighter in comparison to more curved, more rotated, I apologize. So the center is towards me when it should be more that way. So as we look at this leg, is straight as a perfect column. In comparison, it is skewed, as we can see. And so again, knee straight down to the second toe is one beautiful column. The ankle bone right behind each other where it should be. No more bulge. Arches are back where they should be. The big toe is straightened out as well, which was a bunion. The whole structure is much, much, much better. Let's turn around if I may. And now we're looking at from the rear. I can barely see the baby toe, and that's exactly where it should be. Maybe the fourth, possibly half of it, but that's exactly what you should be seeing. They call it too many toe sign, and I don't see that. I see the Achilles is perpendicular. I see the heel is straight down. I see forefoot to hind foot. The front to the back is straight. The arches where they should be. The ankle where it should be. The leg where it should be. And so that in comparison to, let's assume, that one. So we're gonna go backwards, and we can see the difference. So face me again one more time, I apologize. So we are looking at both feet. I will definitely take this side in comparison to that side. So the lighting is not that great, but you guys can see what I'm talking about in comparison. Okay, so now we're gonna show you one more thing.